Good afternoon, and welcome to today's event, Evaluation and Management, Physical Examination. This is part 2 of our series of part 3, Embrace the Gray Area That Can Lift Service Levels, brought to you by InHealthCareSupercoder.com. If you're like many coders, you love coding because it's black and white. We all love things that are black and white. Here's my 4-year-old daughter, who's thrilled that the zebras match her black and white outfit. For coding, black and white means that either a code's right or wrong, but coding really isn't that simple. We have to understand code descriptors to make sure the procedure, service, diagnosis, and/or supply documentation matches the CPT, ICD-9, or HCPCS description. And then sometimes the defining line between one item and another is not as clear-cut. Evaluation and Management Services' second key component, physical examination, is one of those gray areas. Now don't groan. Embrace the gray for 2 reasons. 1, you get to put your clinical savvy to the test, and 2, gray means you can make your doctor's documentation work for him. How do you do this? First, you have to understand where terms can fall within the physical examination guidelines. Then you have to increase your vocab savvy. That way you can place terms in various areas as appropriate. The nice thing about the examination component is that it's the only detail you need to evaluate to determine a code's exam type. In history, you need to look at HPI, PFSH, and MDM. Check out Part 1 and 3 of the series if you need a course on history taking or medical decision making. There are 4 types of examination: problem-focused, expanded problem-focused, detailed, and comprehensive. All you need to determine is the type of exam, what level examination the physician's documentation supports, and you've locked down the examination type. Let's get started by looking at the standard CMS audit sheet from Highmark Medicare Services. I'm going to cover the box from the bottom up, focusing first on the exam body areas and organ systems. This is called the data quantity area. So if you hear an auditor talking about the data quantity area, this is what they're talking about. You need to be able to identify in documentation the 7 body areas that are listed at the top part of the box, as well as the 13 organ systems listed in the bottom. This will protect the service levels your physicians are claiming by you, making sure examination documentation matches carriers and payers' requirements for those exam types. Most consultants recommend a quarterly or semi-annual internal audit in which you pull a random sampling of 10 to 15 charts per physician. You'll reduce your payback risk if you're ever audited by a carrier payer because you will have already identified your trouble spots and work to improve chart-supported coding accuracy. Now be familiar with your physician's typical findings and know where these usually fall. This will help you quickly count documentation under the various systems and areas. This slide shows another way of looking at the same type of audit tool, and this one includes both the 95 in one column as well as the 97 in the other column. I encourage you to print out this sheet with terms and associated areas and systems and add in the ones you see every day. For instance, constitutional. This would be where our weight, our height, our pulse ox falls, as well as the type of dress, as in general appearance or vitals. Some of these areas are obvious, like rash for skin or integumentary. Others require clinical familiarity, like edema for cardiovascular. The first type of exam, a problem-focused exam, requires 1 body area using the 1995 guidelines, or 1 to 5 bulleted elements under the 97 guidelines. For new patient visits, consults, ED services, and long-term care, which require that you meet the criteria of 3 of 3 key components, meaning the history, physical, and medical decision-making, problem focus goes to 99201, 99241, or 99251, so our low-level codes, provided you're billing to a payer that accepts consultation codes, unlike Medicare. So I'm including the consult codes here, but do just remember that those are not accepted by Medicare as of January 1 this year. Problem focused also goes to 99281 for our emergency department service and our 99324 for long-term care. On services that require the physician perform and document 2 of 3 medically necessary key components, A problem-focused exam is listed with the first levels of an established patient office visit, our 99212 level, subsequent hospital care, low level, subsequent nursing facility, 99307, and long-term care, or 99334. For these services, the physician exam is centered on the body area or body system identified in the patient's chief complaint, or CC. In a 99212, the physician is examining that body area or system only. An example could be a follow-up ear exam in which the otitis media is resolved and the physician examines the ear only. The key that you're looking for is that the physician is strictly examining that one body area that the person came in and presented a problem for or complained about. Our next level of exam is our expanded problem-focused exam. And this incorporates many body areas or systems, a limited examination of the affected body area or system, plus 1 to 6 systematic or related systems with the 95 guidelines. Now, remember, when we talk about counting the number of areas or systems, the physician should only be counting, and you should only be giving credit for performed and documented medical physician examination findings that were done based on the encounter's medical necessity, as indicated by the patient's presenting problem. We don't want to have physicians or coders milking the system, trying to obtain additional body areas or systems that weren't necessary to examine based on the patient's presenting problem. So we're going to talk about counting areas, but I do want you to remember that medical necessity steers your ultimate code selection. That's kind of our disclaimer here. For instance, our patient with otitis media, on initial presentation, has a fever, runny nose, and stomach ache. The physician examines those systems and documents his findings. In addition to examining the ear, which is our one body system, you have stomach, which would count under either abdomen or gastrointestinal. Although the physician also examined the patient's nose, you still only have 2 systems. Ear, nose, mouth, and throat all count as one system, regardless of how many of those structures are examined. If the patient also had goop coming out of her right eye, yes, I took my 5-year-old in on Sunday. I'm in Southwest Florida, and it's usually very nice here in the winter, but we've had the coldest season on record for 30 years. And on our first beautiful 70-degree day, I was in the physician's office for green and yellow goo coming out of my daughter's eye. And yes, she also did have a runny nose. I don't think it was a stomach ache, though, but I would have preferred being outside rather than in there, of course. If we did have the combination of the eye in addition to this example, then we would be able to count the eye as an additional system. The 1997 guidelines require 6 to 11 bulleted elements for an expanded problem-focused exam. Expanding our EMT rule, we want to remember that this rule applies regardless of the body area or organ system. There's one system credit that's given no matter how many findings you have for any given body area or organ structure. So when we're talking about EMT, if you also had rash all over the patient's stomach and you also had white patches on the tongue, your mouth would be counting under your EMT, but your rash would be counting under integumentary.